You can go ahead.
All right, so my name is Yuri. For those of you on the night shift watching this, I'm one of the ICU docs here. If you haven't met me before, I was asked to give a brief talk on PA catheters, and so I want to focus on things that are most relevant to ICU nurses and other stuff that you might just be interested in, such as the indications. Why do we bother placing these PA catheters? In what situations are we thinking about doing that? What the contraindications are. Most relevant to ICU nurses is probably monitoring for complications, how to address those complications, or how help address those complications in concert with the providers, and then some really basic waveform interpretation. So first, some indications of why would we place PA catheters. What have you guys seen us place PA catheters for?
Just evaluate the right side versus left side of the heart.
Okay, so that's a good way to put it. So if we're concerned about RV or LV function being depressed and being a major contributor to hypotension, either most often you'll see this concern arise in the middle of cardiac surgery cases, but occasionally we'll place PA catheters in somebody that comes to us with kind of a complex shock state that has a cardiogenic component and other things going wrong with them, and to monitor the cardiogenic component of their shock to titrate our inotropes. The PA catheter is useful. Any other kinds of patients that you've seen get PA catheters? Kind of along the lines with this. It's kind of a read my mind thing, but patients that have pulmonary hypertension and require surgery. Some people, depending on how big the surgery is, they might place a PA catheter to monitor their PA pressures. What about some contraindications? Really focusing on the absolute contraindications. Who shouldn't get a PA catheter? This is a tricky one from a nursing standpoint because you're not thinking about this, but absolute contraindications are things like infection at the site. So this would be if somebody. What I mean by site is kind of open to interpretation. I guess one way to think about it is we generally don't place central lines through infected skin, but for this to be a contraindication of PA catheter, it would mean that like every site for PA catheter placement has some sort of an infection. That would be pretty unusual. If somebody has endocarditis, that would make more sense to me as an interpretation. As if somebody has an active infection of their heart, wouldn't make sense to go sticking a PA catheter into that. Another one we don't think about because we don't deal with these patients at the VA is an RVAD is a contraindication to having a PA catheter because you've got a device that's basically spanning the right heart, and you don't want this PA catheter to get ensnared into that because the RVADs have a negative pressure component that sucks in stuff. You don't want to clog that up with a piece of hardware. And then there's kind of more relative contraindications that are you can still place PA catheters for people like this, but you gotta be a little bit more cautious. Can you think about some relative contraindications to PA catheter placement?
Maybe if they've been bleeding.
What do you mean by that?
Just like if they are higher at risk for
Oh,
hemorrhage.
if they're coagulopathic. Yeah, that's true. If they have severe coagulopathy, then you do want to carefully weigh the risks and benefits of a PA catheter because they could have any number of bleeding-related complications from the PA catheter placement. There's some thought that if you're really severely coagulopathic, that those patients are high risk of PA rupture. That's possible, sure. Other stuff that people think about are patients that have left bundle branch block are thought to have a relative contraindication to PA catheter, meaning that you can still consider PA catheter, but you need to be really careful. And let me just draw a fuller system of the heart. So if this is where your PA catheter is sitting, I'm going to draw a slightly different picture actually. This is kind of one two-dimensional view. A better two-dimensional view that will make this make more sense would be what are called the 4-chamber views of the heart. Where you see left ventricle, right ventricle, and here you have left atrium and right atrium. And it turns out that the conducting system, the normal conducting system, starts off in the right atrium, makes its way through the right atrium, goes and becomes, passes through what's called the AV node, and then there's two electrical bundles called the bundles of His that simultaneously are supposed to transmit that electrical signal to both ventricles at the same time. What happens if you have a left bundle branch block is that this part of the pathway is impaired, and so the way that your heart gets, your ventricles are told to depolarize is first the signal reaches the right ventricle, and then it kind of inefficiently makes its way to the left ventricle. So you have first contraction of right ventricle, then left ventricle. And when you're placing a PA catheter through a system like this, if they already have the left bundle knocked out, the PA catheter, as it makes its way through the RV, can temporarily knock out the right bundle as well. So you can basically cause a complete heart block. It's a theoretical concern. It happens still very rarely, even in patients with left bundle branch block, that they get complete heart block during PA catheter placement. But it is still possible, so you got to be careful. Another contraindication, sort of relative, this is one that we usually ignore, quite frankly, is severe TR. And the reason for that is as you're placing this thing, severe TR is basically fighting against you. It's, blood flows coming back from the right ventricle to the right atrium, whoosh, whoosh, whoosh. Makes it harder to place these catheters, but it's certainly not an absolute contraindication. And most of the time you can still place the PA catheter just fine. Okay, so that's sort of some background about indications, contraindications. I think the more interesting stuff is when you get into complications, the more interesting / more unfortunate stuff, but it's important to be aware of. So you can break down the complications that can happen with a PA catheter into some categories. Complications during placement, during maintenance of the catheter in the body, and then misinterpretation of data can be thought of as another category. Okay, so when the catheter is being placed, what do you think are some complications to, as the nurse kind of assisting with that placement, that you might try to keep an eye out for? Or some of these are things you wouldn't necessarily be the one to detect, but you should be aware that these can happen in placement.
VT is pretty common.
Yeah. Okay. Perfect. So dysrhythmia. I mentioned the complete heart block if they have underlying left bundle, and then VTAC. Why do you think these patients can go into VTAC during the PA catheter placement?
Probably just irritating the ventricle as you're poking as you go through the heartbeat.
Yeah, exactly. So like I didn't label these structures, but this is your right atrium, SVC, IVC. Notice how these are all kind of one area, and we've just conceptually break them down into 3 separate parts. Here's the RV, tricuspid valve, pulmonic valve, and here's your pulmonary artery, main PA splitting into the right PA and left PA. And it's primarily VTAC and VFib are most likely to happen when the catheter tip is making its way through the RV because it hits the walls and it basically can generate a ventricular arrhythmia. So if let's say you're seeing that, what do you think are some things that we can do if we're, let's say initially it's just non-sustained VTAC?
What can we do from nursing standpoint?
Oh, or not necessarily from a nursing standpoint, but what do you think the overall strategy is?
Just remove it.
There's two different ways to think about it. One is if you're getting some non-sustained runs of VTAC, One is to deflate the balloon and just, come back to bring the tip back into the right atrium and SVC area. Another approach is, if they're kind of short runs of VTAC, is to basically try to quickly thread the catheter through the RV and get it into the PA. And that's sort of dependent on, how hemodynamically unstable the patient is, how badly you need to get that PA catheter in. It's going to be a judgment call each time. But the main thing you don't want to do is you don't want to just leave the tip of this thing flopping around in the RV. You want to either advance it or withdraw it out of the RV in that situation. There's some thought that before placing catheters, that you want to make sure that the patient's electrolytes are tuned up so that their K is greater than 4, MAG is greater than 2. That's always a good idea. I think we do in general a good job of keeping the electrolytes buffed in our patients. So I don't think that's a major reason why they would experience that in our ICU. Okay, so what about other complications that can happen during the insertion, during placement?
Theoretically, you can perforate things or injure the valve, but I've never actually seen either. But
Sure, yeah, injury.
Pulmonary artery rupture.
What's that?
Pulmonary artery rupture, maybe.
Yeah, that's right. And I'm gonna put that in this, because this typically happens during. Surprisingly, it doesn't happen a lot during the initial placement. It's apparently it happens more commonly during maintenance, which is more relevant to you guys. Pulmonary artery rupture. Okay, so this is sort of, people think about this as the worst complication that can happen with PA catheters, because it's very difficult to treat. The mortality is something like 50 to 70% once you rupture a PA. I guess, since you mentioned it, we can talk about, what do you think the management of PA rupture is? Or first, how would you guys, as a nurse, how would you detect, if your patient has had a PA catheter in, let's say, 2 or 3 days, what sign would be the most suspicious to you that pulmonary artery has eroded, the PA catheter has eroded into a blood vessel and has caused the PA rupture?
What's the symptom?
Yeah, symptom, yeah.
Like hypotension?
That would be a sign that might accompany this as a late sign, but what might be an early sign?
Shortness of breath.
Okay.
Saturation.
And what was that?
Desaturation.
Yeah, those have a broad differential. I agree. Those would all be very likely to happen as this evolves. I'm thinking about something really specific that would really identify PA rupture as the cause of their dyspnea, hypoxia, and hypotension, as opposed to anything else that could be going on with the patient.
the only time I saw it, it was not subtle. You just saw bright red blood come up to the ET tube.
There you go.
And it was.
Yeah, hemoptysis. So, if in an awake patient, they're going to be coughing up, in an intubated patient, it's going to be through the ET tube. Yeah, so that hemoptysis in a patient with a PA catheter in place this just has to jump to the top of your list. What do you think would be the management of that, the acute management? In addition to calling a thoracic surgeon for an extra set of hands, there are some things that we can consider doing at the bedside.
Step 1, change your pants. Step 2, literally, like, it was, to get your attention. And then put the balloon back up, and then you put that lung, if you know based off chest x-ray which side it is, but almost always it's in the right side, you put that lung up.
Yeah, or down. I would put it so.
Sorry, you are correct.
Yeah.
Because you want the good lung up, because you don't want the other side to fill with blood.
Yeah, exactly. So, few things you can do. In addition to just inflating the cuff, what's recommended is deflating the cuff, pulling back a couple of centimeters, and reinflating the cuff. That way, you're decreasing blood flow. You're occluding blood flow to the area that has the bleeding going on. Putting the patient right side down if you're not sure where the PA catheter is, and I agree 100% with Brian that almost always it's going to snake its way by its natural curvature to the right pulmonary. This is the left side of the patient. This is the right side of the patient. So right side down. If they're not intubated, you want to intubate them, and if they are intubated, what you want to do is you want to isolate that lung. So hopefully somebody can get a bronchoscope to the bedside, and you want to basically, or the providers need to guide the ET tube. So in parallel with this cardiovascular system, you have a lung system, and here's in yellow is your trachea. And if the bleeding is happening in the right lung, what you want to do is you want to guide an ET tube, whatever ET tube you're placing or is already in place, down and selectively main stem this is one of the few situations where you want to intentionally main stem their left main stem bronchus, assuming that rupture is on the right side. And that way you can buy some time basically so that you can continue oxygenating the good lung. And then the thoracic surgeon can hopefully help you out, and if there's something salvageable surgically that, in some cases, a pneumonectomy would have to be considered. As you guys probably know, pneumonectomy is a very morbid procedure with its own very high mortality rate, especially a right pneumonectomy because that's the bigger lung. So, any questions about that? So basically, everything Brian said. So, alert the provider. The provider is going to deflate the cuff take all the air out, retract the cuff by a couple centimeters, reinflate the cuff, put the patient right side down, unless you have a reason to think the PA catheter is in the left lung, and then secure the airway and try to selectively ventilate the left main stem bronchus. Okay, what are some other things that can happen typically during placement or insertion? There are complications.
Accidentally arterially place it and wind up with a left heart cath.
Okay, yes, yeah. So have you seen that before?
No.
Yeah. Okay.
Not with Swan.
Okay. What are some ways that's really important? Yeah. So this is during placement. The initial placement, we assume that this introducer, when it was placed by the providers, was placed into a vein and not an artery. What are some signs at the bedside that not just not PA catheter or any other central line is in an artery as opposed to a vein?
If the person is well perfused enough, you might see like bright red blood in the artery as opposed to darker red in the vein.
Okay, yeah, so color is a tricky thing, yeah. So signs of intra-arterial CVC. Color's a tough one, but you're right. I mean, bright red is concerning. Sometimes our patients are very oxygenated, and their venous blood can look kind of reddish. So color plus minus. What else?
I see blood coming back up through the tubing, or
Yeah.
one time I even heard how it was discovered is the pumps were beeping because it couldn't infuse against the pressure head.
Good. Okay, so you got pulsatile blood in tubing coming back from that line. What else?
Blood gas results. Maybe.
Yeah, let's talk about blood gas results. Okay, so let's say the provider is not sure. The provider is not sure where they place this line. The blood's sort of in between red and blue, and the pulsatility is there, but the patient has severe tricuspid regurgitation, which means that in severe tricuspid regurgitation, you can actually have pulsatile. You can have pulsatility on the venous side. But let's say your blood gas, we don't know it's arterial or venous, your blood gas comes back with the following. pH of 7.3, let's say 7.29, PCO2 is 45, and PO2 is 60. This is also one for clear here. So what do you think about that set of numbers? Which of these three numbers, which is going to be most useful in differentiating arterial versus venous origin of this?
PO2.
PO2, yeah, perfect, yeah. So you can throw this part away. Okay, so what does this PO2 tell you?
It's probably venous.
Is that right? Okay, so let's draw.
That could be wrong.
All right, so let's draw this oxyhemoglobin dissociation curve, which is a fancy term that describes the relationship between our PO2 in the blood and our O2 sat.
Just went over this. I can't remember what 60 plus 1 is.
Yeah, no problem, no problem. So this is our PO2, and this graph arises from the physical properties of our hemoglobin. When the PO2 gets to a certain point, when you've got a PO2 of 26 millimeters mercury, that corresponds to an O2. That environment results in 50% of your red blood cells being saturated with oxygen, which is called the P50 point of this curve is 26. Then the mnemonic, which is it's sort of a crude mnemonic because the numbers don't match up perfectly, but they give you in the ballpark, is 40, 50, 60 corresponds to SAT of 70, 80, 90%. So that means that a PO2 of 60 maps to a O2 SAT of 90%. When you think about venous blood gases, what do you think about kind of the upper limit that you should see of a SAT on the venous side, of an O2 SAT on the venous side?
50s?
Of a SAT? You could actually go higher than that. That's sort of on the lower side. That's actually on the lower side of what the venous SAT will be.
Okay.
You're thinking of the PO2 on the venous side, could certainly be 50. But the SAT, so venous, let's just do VBG, ABG. This one will be for PO2, and this line will be for O2 SAT. Typically, the PO2 is going to be, in less than or equal to 50 on this side. The O2 SAT should be less than or equal to 80%. Okay. On the ABG side, it is extremely variable depending on how hypoxic you are. But when you get to SATs that are above this and PO2s that are above this, you're pretty much on the arterial range, unless the patient has like something really, really screwed up, like they have cyanide poisoning, such that like all their tissues are poisoned, they can't use oxygen, and all the oxygen is coming back to the venous side. If that's happening, you would know it in a number of different ways. So unless your patient has cyanide poisoning, or something analogous to that, you shouldn't see values greater than these on the venous side. So this looks like a really benign number, but tells you that you're in the scenario you just described, Claire, that you have a carotid stick basically. Does that make sense? Okay. Anything else that we can use? That's one is sort of along, we haven't mentioned this, but it's sort of along the lines of the pulsatile blood and tubing.
If you have like a pressure tube in the kit, you can either attach it to like a CVP monitor or I guess a line monitor, or you could just like something that tells the ED is like if we're pressed for staff around, you can like literally just hook the tubing up, hold it up above the patient, and if it continues to rise steadily, it's probably arterial. If it rises a little bit and then stays and kind of fluctuates with respiration, it's probably venous.
Yeah, exactly. Yeah, that's. People have different names for that. Manometry or qualitative manometry is probably the best way to describe that. Some people call that poor man's CVP. I guess we can call it poor person's CVP in 2020. So that it's those tools that basically give you more descriptive data about whether this is high pressure system or low pressure system. Because as I mentioned, pulsatility can actually arise from severe TR on the venous side. If you hook up the line that you've just set up to a CVP bag, you'll get to quantitatively see what the pressures are, and if you do the qualitative manometry, you'll get to qualitatively see whether the pressure is way in excess of what a venous pressure should be, or in the ballpark of venous pressure. Okay, so let's see. Any other complications during placement that you guys can think of? What's that? Okay, yeah, okay. So you're imagining that we're placing the whole so all the complications of central line placement, pneumothorax, absolutely.
The only one I can think is just malplacement, like it's down in the liver and
okay.
Know where they were at.
Yeah, I could have gone. Yeah, misplacement, and along the lines of misplacement. These are kind of read my mind things, but kinking. Is in nodding of the PA catheter. These are kind of specific to PA catheter. Yeah. So, have you guys ever seen this before? Kinking or nodding? We had one like it was a weird. I think Kevin was here that day. I don't know if you were here that day. It was like basically a patient came to us from the cardiac OR with a PA catheter, and the PA catheter, instead of looking like this on the chest X-ray, it just looked, at least on the chest X-ray, it was like this, sort of all in the RV with this knot. What do you think can be done about that?
blow through the blue.
What's that?
You blow through the blue line on there?
The
I'm teasing. I'm teasing.
Oh, I see. What else? As it, the textbook answer is basically you're supposed to deflate the cuff and then just withdraw this thing back to the SVC, and then inflate the cuff and try again. And if it happens consistently, then you're going to have to potentially you're going to have to deflate, remove the whole thing, and get a new PA catheter because there might be something kind of screwed up about the PA catheter itself that's predisposing to that. Some people with like big RVs are more likely to have that problem because there's more space for the PA catheter to have that issue. So it's sort of a similar problem for kinking and for knotting. You deflate the cuff, you withdraw, and then you try to re-advance and get it back down there. Those are I think the most important the aspects of during placement complications, during maintenance, and then the misinterpretation. So we talked about one aspect of misinterpretation is having a sense of what a venous blood gas should be versus an arterial blood gas. Other aspects of misinterpretation are not knowing where you are when you're advancing this thing. So you'll see us, as we're advancing this, look at the waveform that is being generated by the, and the waveform is coming from what a pressure gauge that's at the very tip of this thing. And so let's draw some waveforms that we should be seeing as we're going in. So I'm going to draw a scale here at the bottom. This is sort of assuming you have a relatively normal patient with relatively normal right heart pressures. Okay, so when you're what's a normal CVP or pressure when you notice how there's an introducer here. When you first bring the PA catheter out of the introducer, the pressure here is is your CVP, right? It's going to be the same. That pressure should be relatively the same whether the tip of the PA catheter is in the SVC, in the RA, or in the IVC, assuming your patient is flat during placement. So what's a normal range for CVP? Yeah, that's pretty good. That's pretty good. Sorry, I'm just getting a message from somebody. 5 to 10. Yeah. So when the tip of this PA catheter comes out of this sheath, you're going to be getting a squiggly line. Kind of looks like this. Okay. And then at a certain point, you should see something like this. What do you think has happened? I'm sorry, do this wrong. What do you think has happened from here to here? Here to here.
From the RA to RV?
Yeah, exactly. Yep, exactly. So this was your CVP tracing. This is your intra-RV tracing. And what would you call this number up here? Would it be, if I were to draw an EKG superimposed on top of this, it would look something like this. Where this is your P wave, this is your QRS, and this is your T wave. So what would this peak number, what number do you think that, if we were to give it a name? Is it? We'll get to wedge pressure eventually, but we're not quite there. Yeah, it's your right ventricular systolic pressure, because we said we're in the RV. This is systoles between the peak of the QRS and the end of the T wave. So the peak of your peak pressure during systole is here, what would that make this number down here? Lowest number. Anybody? Yeah, RVDP, yeah, and that generally should be pretty close to your CVP, because if you think about it, during diastole, this tricuspid valve is open, which means that your CVP and your RV are equilibrating together, so there should be similar pressures, okay? All right, and, okay, so now we keep on advancing our catheter, and, whoops. Okay, what happened from here to here? From here to here. Something has changed about this wave. Oh, I'm sorry, and I'm missing one other thing. I apologize. There we go. Yeah, that's more realistic. So from here to here, from point A to point B. What's that? PA pressure, yeah, exactly. Okay, perfect. So what would you call this, the peak value up here?
So the peak is like when the balloon is completely off.
When the what?
The balloon.
Actually, the balloon, hopefully, sorry, 1 second. Must be spam. The balloon has been up the whole time. As soon as we got the tip of our PA catheter to 20 centimeters, the 20 centimeter mark, we inflated our balloon and we've had it up the entire time as we're advancing. So, what would that number be? Any idea? So it's our PA systolic pressure. Just like our RV systolic pressure is the peak pressure in the RV, the PA systolic pressure is the peak pressure in the RV. What would that make this number here?
PADP.
PADP, yeah, exactly. Okay. PADP, okay. What are some differences between the PA waveform versus the RV waveform that you guys notice?
There's a notch. There's a little notch.
Dichrotic notch, yeah, exactly, having to do with the pulmonic valve and how pressure kind of interacts with that valve. Okay, and this is similar to how this PA waveform should look a lot like an A-line waveform except with lower pressures. What else is different about the PA waveform?
It's higher than
the base is which is what?
Which is about 5 to 10. It's more than that, like 15 to 25.
Yeah. That's right. So this is called a diastolic step up, which means that the diastolic pressures in the pulmonary artery are higher than the diastolic pressures here. Okay, is there anything else different about the diastolic waveform here? From the RV to the PA, and I didn't draw it very well with this. Let me see if I can make it a little bit clearer. So it's more like, let's see, like that. It's more of like a crisp down. Okay. So is there anything different about?
Whoever's taking the heart, it snuck in.
Oh wow. Okay. I'll finish up quickly here. So, anything different about the actual shape of this waveform in diastole between the PA and the RV?
He said diastolic runoff, but I don't know what it is.
Yeah, diastolic runoff. So what he's getting at is, notice how that in the right ventricle, the diastolic pressure is increasing during diastole. In the PA, the diastolic pressure is decreasing during diastole. And why would why would that be? So this is, we're saying this is going down, whereas in the RV, pressure is increasing. If you think about it, it's because in the RV during diastole, that's when the tricuspid valve is open. That RV is filling up as diastole progresses, so that the highest pressure in the RV during diastole should be at the end of diastole. The whole purpose of diastole from the RV standpoint is to fill itself with as much blood as possible. The PA during diastole is serving a different purpose. It's not filling up with any additional fluid, because during diastole the pulmonary artery is closed. What's happening is the volume of blood it received in systole is now running off into distal blood vessels, into the smaller subsegments of the pulmonary artery branches. So that's why there's this distinction. So there's several things that change. To summarize, as you go from RV to PA, you develop a dicrotic notch having to do with the pulmonic valve. Your diastolic flow goes from upsloping to downsloping, and you have a diastolic step up because the goal of the pulmonary artery is to maintain pressure, to capture a volume of blood with each systole, and to maintain that pressure so that it can feed forward that blood. So if the PA diastolic pressure was very low, the PA would be not as good at funneling that blood forward during diastole. It needs to continuously move that blood forward through the lungs in order for blood to get oxygenated. Okay, and then the last phase of this is right here. So what happens, what's happened right here? Probably a little bit lower. So it's actually going to be more like, it's going to be like so. What's happened from point A to point B?
Is it when deflate the balloon?
The balloon is still up at this point.
It's still up.
Yeah, it's been up the whole time. Yep.
Is it wedge now?
Yep.
Yeah. This is a so-called wedge pressure, or pulmonary artery occlusion pressure, wedge. This is an approximation of your pressure in your left atrium. Notice how this squiggly waveform is similar to your CVP waveform. We said this is RV, this is PA, and this is the wedge. It's similar to your CVP waveform because these are both kind of the low pressures that come back to your atria. It's just a slightly higher value. So whereas this is 5 to 10, this is more like 10 to 15 normally. Let's see, anything other than that that's pertinent to you guys. So any questions about this so far? Okay, so then to your point, Padita, about deflating the cuff. So when you get this value, generally you don't want to keep advancing any further because you're wedged. I mean, that means that you've already kind of created a seal between your tip of your PA catheter and the balloon and the adjacent walls of the blood vessel. You don't want to keep shoving that further. You pause. You take note of what that value is at end expiration, and then you should deflate the cuff, and then basically keep it deflated. That's what we, hope the operator will tell you, please deflate the cuff. And then intermittently, if people want to figure out what the wedge pressure is, they can, ask for that cuff to be reinflated. Hey, what's up? Oh, you guys ready? Okay.
Keep going.
Okay, we're almost done.
That's fine.
Any questions about this? Okay. All right. Very good. Well, there's obviously a ton of other stuff. I mean, Brian knows more about PA catheters than I'll ever know. So I really appreciate him being here. But this is kind of a starting point of some complications, indications, and some waveform interpretation.
Thank you so much.
Okay. No problem.
Thanks for that.